joining us, and we wanted to do a collaboration, like walk a little bit through how we look at things at treatment team here at Cottonwood Creek and when working together. So we thought that harmful drug interactions, we wanted to cover more than just drug-drug interactions. We want to talk about is a patient the right fit for a particular medication based on if there's a lack of red flags or what are some of those red flags? And we want this to be interactive, so please put questions or concerns in the comments there. We don't have anything to disclose. I don't have anything to disclose. You don't have anything to disclose. Yeah. So we're covered with the disclosures there. And our learning objectives. We'll go to the next slide there.
So these are learning objectives for today. First of all, I wanted to say, it's good I'm doing this talk with Steve because we've worked together for about 14 years now, and I think pharmacists are just such a wealth of knowledge for us to take advantage of. So if you know a pharmacist, Steve and I talk about meds all the time. So I just think it helps us so much in our day to day. We're always talking about interactions. I mean, probably on a weekly basis, but talking about interactions, things I know about or even don't know about, I'm fine learning things on a daily basis. But anyway, that's why it's cool we're doing this talk together because Steve's helped me out for a long time. So learning objectives today are going to identify available community resources. How do we look at patients' access to medicines? First of all, are they going to be able to get what we prescribe? Have they filled other controlled medications? Hopefully, you guys are all using the prescription database. It's actually a requirement now, and maybe somebody knows the law better than I do, but I end up having to check that and document sometimes that we've checked it. Actually, the Epic system at St. Alphonsus, if you try to prescribe a controlled medicine, takes you immediately to the Board of Pharm to look at that. We're going to recognize the FDA boxed warning for Singular, which is something that, a couple of years out from when this came out, there's still folks who this really hasn't got to every provider yet. Because it's kind of an odd warning. It's a medicine that we wouldn't really associate with that because it's not a psychiatric medication. So we'll talk about that. Apply current valproate prescribing recommendations, and there are some updates. And see, this is something that I learned from Steve. There's some updates as far as Depakote goes, and that's a medicine that's always important to talk about interactions and dosing considerations. Um, be aware of inconsistencies among drug-drug interaction databases and understand their clinical implications. There's something, alert fatigue, where depending on what system you're on, it might flag 10 alerts and which one of those are clinically significant, which ones aren't. Again, just to reference the Epic system, which lots of folks use, just as of this morning, it pops up hydroxyzine and haloperidol, and whether that's, most of us would think that's not significant. So how do we know what's significant and what's not? And appreciate and manage clinically significant drug-drug interactions between antipsychotic and cardiometabolic medications. And maybe too, since we have quite a bit of time today, is talk about at some point how we might approach problematic med lists. If somebody comes in our office and they're on 10 things that all interact with each other, how do we approach that on day one when we inherit some of these folks that might have what we see as problematic med lists? So there'll be lots of time today for folks to ask questions, interrupt, but Steve has put together some really useful cases, I think, to look at. And there's lots to discuss. So.
And we want to just remind you that what we're considering, we defined a harmful interaction as prescribing a certain type of medication to a patient who has warning signs or that suggests the medication may not be appropriate for them. So be thinking about those in your practice and what you use as a touchstone or an indicator of, is this the right patient for a medication that requires labs, compliance, a titration, and what some options are and what you find yourself pivoting to. Does that patient have, a history of substance abuse? Does that person have prior overdose attempts? And do they have a profile that has multiple vague, not clearly defined allergies to medications? Is that person, do you consider that a red flag? If they just say all things from this class don't work for me. And we can talk about that a little bit. All right, so the next slide, our first case here. We have borderline personality, recent overdose on muscle relaxant. So we have a 49-year-old female, self-employed, raised in the church. Prior to admitting, had called 988 multiple times, but was voiced their dissatisfaction upon admission with the resources or the options given through 988. Of course, just as always, patients, you often get unsolicited feedback frequently, and that's just one of the things that came up in the chart. Patient does have a history of trauma. Their medications, they came on alprazolam up to 6 milligrams per day, oxycodone up to 100 milligrams per day, zolpidem at bedtime, your muscle relaxer, carproxolol, and a stimulant. So first off, and feel free to put into the chat or come off mute, is there any identifiable interactions or concerns? Maybe we can hear from the panelists, or if there's one of the providers that's seen a patient like this, that they could. So I'm seeing, I think in the chat, seems like a high dose of Xanax. Exactly. That's one of the things we want you to get it take away from this. Tara, did you come off mute?
Yeah, so yeah, I mean, I think I totally agree. Yeah, high dose Xanax, plus opioid, plus muscle relaxer, plus sleeper. A little bit of that's a very spicy combination, and I don't really prescribe soma anymore. I think most people don't. A lot there are even people who are kind of grandfathered in probably should be taken off of that in general.
Okay. Anyone else in there? So we've got anybody else would echo that the concern of benzos and opioids? Any thumbs ups from like if you agree with that's maybe something you want to avoid. Okay. Okay. And then so make sure I hold on to my notes. So the reason for this person's admission was that they'd overdosed on their muscle relaxer. So one of the questions I have, like if that was your patient, what would you do? Would you be restarting that muscle relaxer? Any thoughts out there? No. Yeah. And that was our gut thought, was that we would not restart that. Is there any other steps if you inherited this patient? What tools are out there that you could use to verify that these are accurate doses of their opioids or their benzos?
Yeah, I mean, I think those did somebody else, was that like the prescription drug monitoring? I think the thing, yeah, the PDMP where you can
Yep.
monitor and see what they refilled. I think what I've run into recently, and I don't know if there are any updates on that, is around if they're getting something out of state or if they left the state for a little while. I know there's some reciprocity, but I didn't know, I hadn't looked it up in a little while, and I didn't know if anyone had thoughts on how to help get some of that information or whether there's any other ways to cross state lines for that.
Not that I know of, Tara. When I've run into out of state, I've gone as far, especially with a medication list that like this. I've called clinics, called
Mhm.
providers just to verify because, and I can tell you what Steve and I did with this case is we, verified obviously through the board of farm, and I actually called providers on this case just to verify they knew these scripts were out there, just to
Mhm.
make sure they knew that we have individuals taking opioids and benzos just as a general rule is kind of my pet peeve and the one thing
Mhm.
I lose sleep over. I think people can get kind of cavalier about it. Maybe you see 100 cases where nothing goes wrong, but we've had a case this year where something, it wasn't our case here, but a case in the community that went really wrong with
Mhm,
that combination. So
mhm,
it bugs me, I can tell you, but those are also two medications, especially oxycodone up to 100 milligrams a day. And when we talk about how to kind of approach difficult med lists, you can't stop either of those immediately. You
mhm,
obviously can't stop the Xanax and stop oxycodone. We have all this idea in our heads that stopping opioids isn't life-threatening like alcohol or benzodiazepines, but coming off oxycodone 100 milligrams a day, there's no way they wouldn't be sent to the ER
mhm, mhm,
detox. So, yeah, I actually verified through the Board of Pharma and calling providers with these. I think if you see something and you're maybe curious if the provider knows, especially busy folks, they might have 1,000 people in their
mhm,
clinic or whatever. It's just, I think, as a courtesy, just to call them, make sure they know, oh, by the way,
mhm.
they're getting Oxy from someone else, or by the way, did you know they're on Soma and Xanax at the same time?
Yeah, and one of the things that I can confirm is that next time you guys log into the PDMP, down at the bottom, you can elect and choose the states that you want to, that it is a collaborative, but you can, I mean, click in to what states you want it to run as a screening, because I believe last time I checked, it's 33 or 34 different states all contribute into the same database. You may have to, like, I believe I have to have a separate one for the state of like Washington. To tap into theirs. And then also some of the other limitations, since we're talking about that, is that I don't believe if you're treating a patient that is maybe filling prescriptions at the VA for some reason is not, required to document within 24 hours of dispensing meds into the database. So, Dr. Behrens, did you have a question?
Is that for me?
Yes, I'm sorry.
Yeah. Yeah, I just wondered your approach with a patient like this. I mean, I've inherited patients like this
Yeah.
before. It's hard to figure out how somebody gets on this combination of medicines, but getting them off is so impossible. And I wonder, can you set your goal, like to think, well, I'm going to get them completely off the benzo, or I'm going to get them completely off the narcotic. You just may not get there. Have you ever like set for a lower target? Like somehow you got to keep the patient coming back to see
Yeah.
you. And if you get too aggressive with this, and then my follow-on question is, how do you get somebody off of Ambien? Here's an allegedly non-addictive medicine. I find it so hard to get people off of that.
Yeah, they'll just tell you they're not sleeping. It's the only
Yeah.
thing that's ever worked for me, and
Mhm.
now I can't take it. I think it's really hard to get folks off Ambien.
So,
Uh,
so instead of being a purist, I don't try to get to nothing on some of these, but if I can just I don't know, how do you hang on to somebody like this?
you know what I tell them is I first sometimes I take a deep breath because it used to just make my heart race when I would inherit these folks, and I think to myself, I didn't do this. They're still breathing. So let's just make sure we're going in the right direction. And that's what I tell them too. I give them the long view on day one. And then people can say I'm wrong, but sometimes I won't change anything on day one. I'll say, you've been on these for 10 years. We're not going to change it. If I think they're going to live till their next appointment, this list makes me worry about that. But I tell them like we we're going to get you down. I don't think you should be on Xanax forever, but we're going to go at a certain pace, and it's a lot of reassurance on day one. And I always figure with the benzodiazepines, as long as we're reducing, like in this case, I'd probably target the benzos first only because I'm not the one prescribing the oxy. If they're seeing a pain doctor, they're doing their thing. But so I would target the benzodiazepines, and just unfortunately, you're going to have to go slow, or like you said, they're not going to come back. And what I document in my note too, I will document these medications are immediately obtainable from 10 other providers within a mile of me today. So that's why I'm going a little slower, because they have to keep coming back. And if you go slow, I've had literally these med lists where we've gotten them off Xanax, but it's taken a long time. Or I had a 24 of Dilaudid, 30 of Valium, and a Soma patient and Adderall. And we went down really slow on the Valium and we got there, but it took us a long time to do it. But if you let them know the goal up front, I mean, they can decide to come back, but it's a lot of reassurance, I think, when you first see these folks that, hey, this isn't probably the right long-term plan. I care about your long-term health, so we're going to chip away, you know.
Yeah, I
Yeah,
think what I overheard was there during treatment team was there was you start to initiate some of those uncomfortable conversations where at a certain point um, the patient's convinced that they are fine managing their benzos along with their pain meds, but we have to reflect back upon what got them admitted to our hospital was that they had and then made an overdose attempt with their muscle relaxer. So that the we our team here offered alternate therapy, different muscle relaxers as options and documented and took a thorough history of what they'd used in the past. We did not reinitiate that. I guess the question I would also ask for the group is you have somebody on a benzo, a muscle relaxer prior to, and a stimulant. Are there any, like, what's the overall goal? Or, and maybe like one of our providers can like open my eyes to, because this is a pretty common, um, it's common for us to see a similar med list. So, um, any justification or that of how someone gets to that point.
I think the benzos and stimulants combination is always an interesting question. I mean, are we starting a fire and then having to put it out? Or are we treating two, separate entities? Are we just starting a fire in the morning and initiating anxiety and then we have to cover it up? Or so I ask a lot of questions when I see that combination, you know?
So I guess I think one of the suggestions that I had for this patient was metaxalone, a different muscle relaxer. A lot of patients aren't familiar with or haven't like immediately been able to say, "Oh, I've tried that; it doesn't work for me." Um, would have been is one of my suggestions for this patient, and they took a thorough history based on the patient's pain history, and they like they'd done quite the trial of Lyrica for this patient. So other stuff had been done stepwise, but as a provider, you obviously want to document that each step. If you go to the next slide, it'll what do we have in the to see on nuance at times?
And Eric has a really good comment in the chat. I think it'll come up a couple times today. Is we were seeing we see Adderall every single day, and you certainly don't. You want to make sure you're treating folks who have ADHD appropriately. But also this it's a very good comment in the chat. New onset diagnosis of ADHD in patients to justify the stimulant treatment. Always the question is, how are they making this diagnosis? Is it you've probably all seen the adult ADHD self-report scale that we can all fill out. Mine will be positive, and I could get Adderall in 20 minutes. So I think making sure it's the right diagnosis. Always, it's a good clue if they, had a childhood diagnosis. If they've done neuropsychological testing, it's ideal. But think how hard that is to get. So I agree about the comment about ADHD nuance that. Yeah.
All right, so we'll go to the next slide there, and I think we kind of already talked about. And maybe there's some suggestions out there. How do you guys chart or keep access and verify? I think some of the EMRs track that. I do know that like the PMP, what the Board of Pharmacy has access to is they can look at a particular patient's provider's profile and see how often you have accessed the PMP in your prescribing habits. And since it is a requirement for providers in the state of Idaho that are writing for controlled medication, the expectation is that that you would a provider must register and use the PDMP system to comply with Idaho law. Do you guys find and see that being more integrated in your practices of your EMRs or your documenting? How has anyone got any tips or tricks or because I don't know that it requires that you do it every time, but I believe that, when you obviously if you're doing a dose change, I would recommend it. Or if you were managing someone and if you're charging for a medication checkup, would want to be.
Yeah, and this is a good thing to bring up. I know I'm glad Steve brought this up because we all freaked out when this came out for outpatient use. You know, when you have, we should all be doing this, but when you have 25 patients in a row, are you able to check the Board of Pharm as you're supposed to? But when it first came out, I mean, we were documenting when I still had an outpatient clinic in the note. You know, I checked the Board of Pharm, checked the Board of Pharm if they were on any controlled medications. So, I don't know. Yeah, I don't know what EMRs you guys are using, if it's integrated. It is integrated into Epic, like I was saying, but
Okay, and then I guess one of the questions that's right up there, do most of you call other providers on this report? Is there any opinions or anybody that be willing to that has done it or just to verify?
So I think, yeah, the Epic PDMP is super easy, and they actually have a pop-up that's actually pretty hard to ignore because it's part of your like secondary sign out on any controlled substance. So I feel like that really does. I try to check it on just about everybody. And then I think calling other providers is probably, and even the pain contracts, like I'll have people, and we don't manage a lot of chronic opioids in our practice. We try not to because it's just, but honestly, that there are cases where you have to. So I think we try to update our paying contracts every year. But again, it's like in a busy primary care practice, it's really hard to stay up on it every year, especially in someone who seems good. And I think what's hard is the people who fly under your radar kind of tend to be the ones that I had someone pop up with a methamphetamine kind of psychosis who was on stimulants and had been so appropriate the whole time. This was quite a few years ago, that it was really like a shock. So I think it is like making sure we're being consistent and with everybody on some of that stuff. And it makes it easier if it's like a built-in system for sure. Because if that just is going behind the scenes, I know the residency had a nurse who would analyze because there was a lot more of that in at Full Circle, like at the residency when we were there, and they had a nurse who would actually cross-reference when someone got their refills and then make sure their paying contracts are up to date. So it was on autopilot. And that is probably something with like pharmacists and or nurses, like if it can be streamlined where it's just happens, that's probably a lot easier than us having to remember each time as providers for sure. That
Does anyone know of any like available tools out there that if someone was looking at what a standard pain contract looked like, that we can steer our providers to out in like rural Idaho, or does anyone have any ideas on a benzodiazepine contract? Does anyone use that? And while you're thinking about that, I'll look at it looks like there's a question about, does the Idaho Prescription Monitoring Program have a mechanism to allow for family members of concerned folks to create a paper trail for someone who may be misusing their opioids? I would go to the Idaho Board of Pharmacy. I don't know that there's a mechanism that I know of. I know there's some other pharmacists on the call here today. Be interested to pick their brain of like what they would suggest in that case, and who to alert.
you know what family members can do or concerned people. 10 years ago, Rachel Root called me about one of my patients and told me they were abusing one of their medications, as a counselor. And family members can call a provider, even if there's no release of information, they can call and just leave a message. I would get voicemails in my clinic, not often, but it would be, I'm so and so's mom, or I'm so and so's spouse, just so you know they're taking triple the dose at night and running out. Not that that was common, but they can leave a message and I can do whatever I want with that information. I'm not giving them any information. So family members can call the provider. Typically, I would have that every once in a while. And then again, using Rachel's example of 10 years ago, counselors, if they're concerned, they could call and just say, just so you know, they divulged they're taking 30 milligrams of Ambien on Mondays and then not using the rest, anything. Because you can express concern. They don't have to share information. So I think family members can do that. Yeah, sure. If you know the provider details, no, that's a really good point. Yeah. I think it's difficult when folks are misusing these because providers unfortunately get so busy or seeing so many folks that I think some of these people fall through the cracks for years.
I will say that I really appreciate if I'm a prescriber and I hear from a counselor or someone or a pharmacist, like I've had pharmacists call and be like, hey, this just popped up on the PDMP. Were you aware? And sometimes I am, and I've kind of documented what I feel is appropriate, but other times it's really useful so it's always, I would say, err on the side of the communication. And I think, it's tricky too. I mean, I know we had one come up at one of the local hospitals and a patient where we contacted her doctor and she was actually really upset by that. And it was kind of an interesting situation because she was actually seeing a specialist who did not know she was using illicit substances. So definitely a different situation, but and actually for coordination care, I don't think there was no true illegal that wasn't actually, I think there's some rules about that, but when it comes to mental health and addiction stuff, I know there's layers. And so it was a kind of a tricky situation because I think just knowing what the laws are, knowing how it applies is really important. And then erring on the side of communication, as long as you're within those bounds, a lot of times is definitely in the best interest of everyone involved, for sure.
And Andy,
Yeah, I really would. Tara pretty well said it. I was just going to echo what's being said. I would hope anybody who's counseling with any of these patients wouldn't hesitate to call the doctor because I think certainly in family practice, I would hope we never put somebody off who gives us more information. It's just like you mentioned, Corey, we have such a busy schedule. I'm happy to get any information I can from anybody. So I hope we don't scare
Absolutely.
people off, you know.
No, those voicemails and what I would do with those voicemails when I would get them, especially if I didn't have an ROI, I would take that into the patient and say, so and so left me this message and they were these concerns. Or when I had that Rachel Root patient, I said, Rachel called me. So I bring it to them and say, here's the info I have. But I agree, gosh, with how fast we have to go, unfortunately, having all that information is so useful.
all right. I think we'll move to the next slide. What do
Oh,
we?
yeah, one more question from Jacqueline. Who would we share or report to if we do not know who the provider is prescribing the medications?
That is a really good question. I certainly don't know. I think yeah, that is a good question. If we don't know the provider, yeah. I mean, you express concern to the patient, but a lot of times these folks don't see it as an issue, if they're stuck on these.
Yeah. All right. So we'll move on to the next. Oh, you have a thought?
One thought. Ashley had a good comment earlier up in the chat when we were on the other slide. Just really quickly, because this comes up at least weekly for me. This idea Ashley said about if they OD on a medicine, is it always off the table for use? And that's always but people, you'll hear both things. Certainly in our hospital, you'll hear both things. In fact, sometimes say they overdose, let's use Zoloft as an example. If they overdose on Zoloft, it'll pop up on their allergies. They can't take Zoloft because they overdosed on it. I can tell you, I look at it, and if somebody's aware of some study, I don't know, please let me know. I think of the circumstances of the overdose, because let's use a patient I had in the past who was stable on lithium for over 10 years, stable, doing well. They have a breakup, they get intoxicated, and they overdose on the lithium. They have 10 years of stability, and then due to a specific severe stressor and their inability to cope, exacerbated by alcohol, they overdosed. I don't think in that case it was the lithium that caused them to feel this way. In fact, lithium historically been a really good medication for them. Now, if they've overdosed on a medicine and I put them back on it, I certainly document very carefully. Or another case I have, if they overdose on something and I can't restart it because of serotonin syndrome, risk of NMS, other things. But if it's a medicine that they've historically done well with, they overdose due to other circumstances, sometimes I will restart it. The opposite would be if I started Zoloft is another case I have this week. If I started Zoloft and in 2 weeks they became suicidal, no, I'd never give them Zoloft again. You know, they overdosed on them in the context of the Zoloft. They thought it made them much worse. So it's how you document, and I think the circumstances. And so I think sometimes, no, I think sometimes if they overdosed on something, it's like if someone overdoses on Tylenol because they're depressed, you know, I think in the future they could use Tylenol. You'd want to document very carefully about them having lots of medications they could overdose in a fatal way. You know, someone who has a history of overdoses, maybe we avoid amitriptyline, maybe they don't have benzodiazepines at home, things that would be fatal in overdose. But I think it's a balance of all those factors in that. So that was a really good question to ask, Ashley. So that's what I had.
All right. So our next case.
Sorry, Steve,
Oh,
one
go-
last thing. I'm gonna put a link in. I found a prescription abuse reporting. I actually haven't used it, but it's a great thought. There's a prescription abuse reporting in the DEA website that's like the US DOJ that looks like you can put in whatever information you have, and then that can get funneled. So the Board of
that's cool.
Pharmacy or whoever's kind of, I don't know how effective it is, but at least I found that. And then I just looked up sample opioid consents. There's one on the FDA, CDC website. There's a bunch of, so I'll email them over to Shannon and the team, and then hopefully we can get those on the website. But there's a bunch of samples. St. Luke's has their own, but they're really, I think, finding one that works for your population. And I think we have one that's sort of general, but then we also have a benzo specific and an opioid specific with some specific things in. With the general, sometimes I'll just like initial and kind of update a couple things on it for the patient to make it more specific. So
Okay, so our next case, we have a 17-year-old female that was admitted here at the hospital. A student, lived with both parents, financially stable, with a younger sibling. Reason for admission, they stopped taking their psychotic and psychotropic medications 3 weeks ago with the wording she used. It made me feel dull. So obviously, just a reminder, like we can put together the best plan. And I really did appreciate a slide that was shared a couple weeks ago by Dr. Sacklin. The the least expensive medication you can use is the one that works successfully for the patient. And, you know, just in the statement, it made me feel dull. Reminder about checking in of those side effects if they're changing doses, or in this case, if there's multiple medications, that they know that they're not a burden if they reach out to their provider. So the patient had previous trials of bupropion, fluoxetine, sertraline, and generic Adderall there. And patient had been through the system a couple of times. They'd used some PHP services twice, IOP services twice. They'd been inpatient a couple of times. Upon further discussion with patient and family, mom states she does better when the patient's taking 10 milligrams daily of aripiprazole. Medications not taking as covered above, identifiable interactions or concerns. And since we're treating a 17-year-old, feel free to mention any tips or concerns you guys have as providers that you have to involve parents. So any identifiable concerns.
So, I mean, oh, go ahead, Andy, please.
I was just going to say she could be cruising along just fine on the aripiprazole, and then somebody adds in something like bupropion and fluoxetine, and you've essentially bumped the level up for the
Mhm.
aripiprazole. And that so often when patients say this medicine made me feel dull, and then they just stop it, I'm so frustrated because it usually doesn't mean it's the wrong medicine. It means if I had half a chance to just decrease the dose, we could be in a place where it might work for them.
Yeah. Okay, what if I told the group upon further, the next day, digging deeper, what was divulged to our provider here, was that the patient admitted to the provider poor compliance with previous medications, and that they had experienced and been a part of alcohol, marijuana, and nicotine abuse as a minor. Would that change the medications that you might want to prescribe for this patient to address all their diagnosis? So I guess what I'm kind of asking, if there's a history, okay, next thing,
Yeah.
yeah. So if there's a history of abuse, what kind of but for like we'll break it down for ADHD. Like would you might want to do a trial of a non-stimulant, correct? And um for a patient who's shown lack of adherence, and so we still got some stuff of like, you know, I guess, how do I ask this? What medications would not be ideal? And we've kind of touched on this as far as, or be a poor choice for somebody that doesn't have a strong track record of being compliant. Those like narrow therapeutic windows, like, or lithium, or something that need to be tapered and taken consistently, like lamotrigine, because you might be thinking, is it depression, or is this person bipolar, right? We could talk about how people, there's a long time till people are diagnosed with bipolar. What are there any other options out there that somebody could suggest that might be a good fit, or that you would want to suggest for this patient?
I think sometimes if they're abusing stimulants, I think sometimes we certainly look at Strattera. I don't know if anybody's had better experience than I have with atomoxetine or Strattera, but usually folks, if you try to switch them from a stimulant to Strattera, it doesn't go terribly well. Eric makes a good comment in the chat about the complex diagnoses list, and if somebody's using marijuana, what was the other thing? Marijuana, alcohol,
and nicotine.
So really, what is the diagnosis? So I mean that, and that can be tricky to figure out. If in this case, family's telling you that Abilify 10 helps. So as we clarify diagnoses, maybe that's reasonable. But there is a study looking at, actually, if we treat, say it's real ADHD, I mean, we're talking about an actual diagnosis, not a 3-second kind of screening. If you treat the ADHD effectively, it's actually going to, and Dr. Barron mentioned this months and months ago, they'll actually decrease their risk of specifically marijuana, but probably other substances too. So if you actually treat a real ADHD diagnosis effectively, it probably lowers their risk of their substance use. But then what do you do if they're abusing the stimulant? So those are tricky cases.
We had one more comment in there from Catherine. As a therapist, I'm thinking about parental support / involvement, as well as investigating if there's trauma. Might have missed if you mentioned that.
Yeah, and from what I remember from reviewing it didn't have specific trauma. Seemed like the parents were well engaged, open, based on they had sent the patient to PHP and IOP and been supportive of previous inpatient admissions. If all of our parents and guardians could be this open to that would be fantastic. And so I'll have you advance the next slide. Yeah, so in this case, what our provider strongly suggested, and then we started with the patient, was putting them on, even though they're a minor, a long-acting injectable of Abilify, feeling strongly that was a good fit, and that our provider was adamantly against the use of previously mentioned mood stabilizers like lithium for this patient, or restarting a stimulant. And so I think we kind of touched on a variety of those there. Any comments from our panelists or anyone there before we move to the next
Well,
case?
just really quickly, Steve, since you brought up long-acting Abilify, and since we're here with a pharmacist, there are so many options for long-acting Abilify now. Just make sure you get the right dose. I mean, there used to be just Maintena, and we all kind of trained with Maintena, and now there's Aristata in 10 different forms and these different doses. And 882 is stronger than 1064, and all these little nuances. You can absolutely look it up, but if you know a pharmacist, I usually just say, hey, help me. So there's lots of different Abilifies. Just make sure you get the right one to equal the oral dose you're giving them. Just that's a little quick thing.
Yeah. And if you don't end up knowing one, call the pharmacy here at Cottonwood.
The best
We'll
pharmacist.
we'll talk you through long-acting injectable dosing. We're happy to do that. All right. So I think we're all right. So next patient. All right. So we have a 21 male, 21-year-old landscaper, high school degrees, planning on going back to school, no psychiatric history prior to admission, recent breakup with a girlfriend of 2 years. The emergency room talks, there's nothing like identifying as far as abuse of different stuff. Having increased suicidal thoughts, sleep disturbance, and agitation. Maybe it led to the breakup with the girlfriend of 2 years. Medications, loratadine, a generic Advair. Once again, you got some zolpidem, melatonin, cyclobenzaprine, monoglucas, trazodone, and an albuterol MDI inhaler. So looking at this med list, what are the two things that stand out? What are like identifiable indications? Got some maybe asthma or COPD, right?
Yeah, the same. Yeah.
Right. And
When did you start the singular?
oh, so in the room here, there's a question about when they started the singular, and I think they started the singular 6 weeks ago.
Okay.
And but the person's a landscaper, so I mean they kind of you need to be able to breathe, right?
Isn't that what the lure is?
Is there any concerns with when I see this patient admit, I get concerned about what is actually doing the lifting of this person sleeping. Because part of it is that they have sleep disturbance and they're agitated, right? So are there any strategies out there as far as, so we obviously we want to do a history of how often are you feeling like, are you taking all of those? Because you have a muscle relaxer on there. So here, what did I find? For the Ambien, so this is for a male, and they filled 5 milligram Ambien number 30 only once in that last 90 days. So what does that tell you? Maybe that they're not using it every night, which is like, quite frankly, refreshing. Majority of our patients would not attempt a night of sleep without Ambien. So go there, and we'll go ahead to the next slide, and I'll read some more stuff from here. So the patient talks about working extra shifts to save up for college. You did ask about the sleep meds. How are they providing relief? How often are you taking the zolpidem? PMP confirms they only filled 5 milligrams, 30 of them once in the last 90 days. Admits that he has to use more over the last 2 weeks than in the previous months. Is the trazodone being taken scheduled? Yes, taking 100 milligrams nightly. So one thought you might my suggestion would be, would you consider where are we at? Where are people at as a dose of trazodone 100 milligrams? Is that max dose, or Or how do you guys feel about that for sleep? Now here we'll hop on. Andy, so is even appropriate to combine two different sleep agents? Yeah, that's kind of one of the things that we're talking about. Like, is
You can go higher on the trazodone. I mean,
yeah, and
I
that's
don't know
kind of
as
where
I've
we
ever
have
put
to.
somebody, I've never wanted to put somebody on two different sedating things at the same time. I'd rather find one that works, even if I have to go to a higher dose.
Yeah, yeah. And my default kind of is that I would love to see of these meds here. I'd love to see a trial of the melatonin be maxed out at 12 for multiple nights, or as long as the patient's willing to try that. And then if it's not working, remove it completely so it's not just hanging out there. And then, a healthy dose or trial of trazodone, you know.
Yeah, Andy, I agree with you. I think so often we see folks on three things at moderate doses. They're on three things at low doses rather than just optimizing one. I think in a list like this, when you see multiple sleep aids, I think when in doubt, we kind of deprescribe. Steve gave a talk about deprescribing a year or two ago, and that's really sometimes they'll come with a kind of these non-specific vague complaints, and you look at this med list that they're on, three meds for their mood, three meds for sleep, and you don't know what's a symptom, what's a side effect. So I think whittling away and kind of, approaching it that way, that frankly, you're just on too many meds. So why don't we simplify it? Has the melatonin ever helped? No, it's never done anything for me. So why are you taking it? Have you ever taken more trazodone? No, I can't take more. It makes me tired. Get a feel of what they're doing with what med rather than just throwing kind of a grenade at their sleep.
And so one of the other things that I have in there, how often are you taking the cyclobenzaprine? The patient's answer was 2 to 3 times a week based on body aches at work. He works outside. How often are you needing your albuterol? Last filled inhaler 2 months ago and still has approximately 60 doses. So just so people are aware, most inhalers in the community are going to come with like 180 or 200 doses. So it's always good to know what the starting amount was to determine how often they're needing it. How long have you been taking a current fluticasone salmeterol? 3 weeks. How long you've been taking the montelukast? Excuse me, 3 weeks. Also there. And have you switched or rotated your antihistamines? No, he's been taking antihistamines for the last 3 years. So I don't know if other people have found this, but I know that like some of the providers I've gone to, if you're a chronic because of you live in the Treasure Valley and need to take, uh, you know, um, generic loratadine or Zyrtec, you may want to every 6 or 12 months rotate to see if your body can get used to breaking that stuff down, um, and being so that it's still effective or you get back to that maximum effect as a baseline. And then we'll go to the next slide. The kind of giveaway is that a lot of people just need to be aware that montelukast on the next slide. Yeah, it's got this boxed warning of serious neuropsychiatric events, which when you look back at it, that's exactly like sleep disturbances listed there, agitation. And how does that manifest? It manifests and changes to long-term relations. And in the case, you saw that there was a recent breakup with a girlfriend of 2 years. So maybe you guys can speak to what that looks like on the other side, but it's unfortunate the person had to be admitted for this to
Yeah,
be
no, I
found.
think it's like it still is a newer black box warning. I mean, what has this been, two years? So
Yeah.
I think this is going to take a moment for us to all remember this. I mean, it's finally stuck in my head. So this is a good one to mention, and you will see this come up.
All right, and I guess we're short on time here, so we'll try to get to these last couple of ones so I can get some takeaway. So you have depression or bipolar, recent increase in feeling of sadness. A female, 26, stay-at-home parent, college degree, mother of two, a 5 and a 2-year-old, which is always tough when they have to be treated here. Treated for off and on for depression over the last 10 years. trauma, recent loss of multiple family members, grandparents, and oldest siblings. This is the list of meds: levothyroxine, methylphenidate ER, sertraline, pantoprazole, fluoxetine nasal, and clonazepam. Any identifiable concerns with that? The only one that comes to mind, there is some of the different ER formulations along with your PPIs can, if you have somebody on a PPI and they're on a methylphenidate, some forms are like dependent on pH of the stomach. So if you're altering the pH with the PPI, you may be changing absorption of their stimulant. And we'll go with the next slide. See if we can get through these. Depression or bipolar. So following like questioning with the patient, you've asked to determine like if you think that like bipolar is there. If you were to start treating this patient for bipolar, which mood stabilizer has had a recent change to recommendations of who should be prescribed that? And we'll cut to the chase there. It's the valproic or Depakote products. Not only that had APA will, I believe, have you anyone under the age of 55 that's a female. If you're wanting to continue or have them on that, you need to have a second opinion. If we were in Europe, you have also to continue this medication in Europe, you need to get a second opinion, even if you're treating a male. So here on the next slide, you'll see some of those that information captured. Men and women under the age of 55 should not be started on valproic acid without two specialists signing off on the prescription. And of course, if you are going to put them on that, it would be appropriate that you have them on birth control or have counseling and take steps for that to avoid issues there. And then do you have any thoughts on that?
No, I think it's a good time to mention we all should just be really cautious of Depakote in females of childbearing age. You know, where I trained in Baltimore, we never, or I never saw this. I see it here. I just think we have to be cautious and document very carefully if you were to ever use valproate in a female childbearing age. So even today, I dealt with this earlier this morning. So yeah.
And then I appreciate, thank you, Tara, for forwarding on this article that we'll next talk about, which opened my eyes to. So if you go to the next slide, drug-drug interactions. It was a retrospective study where they looked at drugs.com, Medscape, DD Enter, which if you're not familiar, that is a European-based drug-drug interaction. And then ANSM Thesaurus, which is a French, the French National Agency for Medicine, uses that for interactions. And what they found is that there is massive variability between these four major drug-drug interactions, where, and you'll see it in the references, you can take a look, but they don't all flag for the same interactions, which is concerning. And then what they did find is that, but they consistently did find there's a lot of antipsychotics that interact with cardiometabolic medications. So not just your typical blood pressure meds, but also some of your diabetic meds and the interactions there. So apologize that we didn't leave a lot of time for that.
Steve, would you mind sharing the resource you use for interactions?
Yeah, so I use
prefer?
like facts and comparisons because that's what like my current employer provides, and we also have clinical pharmacology. And I'll, when you come to me with a drug interaction, what I'll do is I'll take a look at one, and then I'll go and confirm it in the other. And specifically after reading this, thank you, Tara, for sharing this, and see what are we seeing. But the reality is never forgetting that it's an N of one, and what you're seeing with the patient, maybe it's not captured in the literature yet. So, Tara, did you have any thoughts? I know we may just have to save the next case, or or journal review for our next session. But is there any?
Well, I was just gonna say, I think I think this one of the things I love about our Echo is that we talk to a lot of people. We're all different kind of specialties or roles on the team. And so I think both like if a patient starts a medicine, and it's fascinating to me how some people are all over it. They're like, I think it's the medicine, for better or worse. Sometimes it's not the medicine, and I really want them to stay on the medicine. But I think some people aren't thinking that way. And so anyone who can identify like, wait, what changed? Because also people are taking a ton of stuff over the counter. I'm using Gabby. We finally have a pharmacist in our on our team, and I will send people to just bring in their supplements, because even things like all the different supplements that have calcium, like I think people aren't always aware of how powerful those things can add up to, especially our older adults just
Or
gets
decrease the absorption. The intent is I wanted stronger bones, but it may be affecting the pH and maybe
exactly.
affecting like
Exactly.
if stuff is truly on board. Yeah,
For
here at the
sure.
hospital, we really discourage supplements that we don't provide because we have such a lack of ability to assess the interactions with the
Mhm.
medications that we're starting for the
Yeah.
patient. And we often have the uncomfortable conversation that those current set of supplements are what got the person still meeting criteria for admission.
Mhm.
That's not always fun to have to deliver that message. So,
Interesting. Yeah. No,
Well,
thank you.
we are just out of time. We're a minute over today. Coire and Stephen, thank you guys so much for this. I know we had, looks like just a couple more slides, but those slides are on our website, so you can access them there. And then Tara sent me a couple resources, which I will upload this afternoon. So if you're looking for those, they will definitely be there by tomorrow at the very latest. So thanks, everybody. We're going to be back on Wednesday, February 4th from noon to 1 p.m. Mountain Time. We have Rebecca Fayette, who is a nurse practitioner with Illumination Women's Health. She will be presenting about hormonal impacts on mental health during menopause. So hope to see you then. Thanks, everybody. Have a great rest of your day.
You guys here. But she's why are you looking?